Okay. All right, we're gonna talk quickly about special tests for the shoulder, starting with the rotator cuff for full thickness tears. The prediction rule is that if we have a positive drop arm, positive painful arc, and positive infraspinatus manual muscle test, all three of those lead to a specificity of 87%. So drop arm is as easy as we just let me bring your arm up for you right here. All right, now don't let me drop it. Easy as that. We stay here in case they do let it fall so it's not super painful. If it's positive, the patient will say ow or not be able to hold that position. Follow that one. Actually, I lie. Before that one, I likely would have done in the clinic just active scaption, so straight up over your head, Brady. And if it's positive, he'll typically say ow within these ranges from about 60 to 120. Jaw's popping.
Yes.
And then if it's not positive or painful within those regions, that would be a negative test. To perform the infraspinatus manual muscle test, if we're just gonna screen, we can do it in this position and press in. He's resisting internal rotation, pressing into external. But if we're gonna be accurate as far as the literature goes, I'll have you lay down on your side because we need it to be against gravity. And then have you lift up to about my arm, hold right there, press down, and we're looking for pain. You can sit back up. Looking for pain and or weakness. Obviously, if it's painful but strong, we're looking at more of a mild, either tendinopathy or tear. If it's painful and weak, looking into more of that moderate to full thickness tear. And then definitely if it is weak and painless, we're looking at full thickness to a neurologic injury. Park et al. Had that clinical prediction rule and also added on if you're greater than 65 years old, that increases the positive likelihood ratio. And in this video, I'm only discussing how we rule in these conditions. So leaving out sensitivity there, in which we would use an empty can to help rule out. But and then going from a full thickness tear to a tendinopathy, we can still use that prediction rule. We could also switch over and incorporate the subacromial pain prediction rule because it still uses the infraspinatus manual muscle test, still uses the painful arc, but rather than doing drop arm, it just uses the Hawkins-Kennedy test instead. Mostly because this is testing for impingement, but it is impingement of the supraspinatus tendon. So we've got their arm in this position, and we're moving into horizontal abduction and internal rotation here as we go across testing, looking for them to say, ow, does that hurt? And really, does that recreate your symptoms? If we wanted to get really specific, Kelly et al. Has some EMG studies to look into the specifics of the rotator cuff. If we were to look at specifically the supraspinatus, the highest EMG for that muscle is the full can position. So arm is upward at 90 degrees, as with the forearm neutral, like we're holding a can, just resisting into extension there. To switch that, obviously for infraspinatus, we can do elbow at the side at 90 degrees of elbow flexion, pressing into internal, resisting. If we want to make it a little bit more specific, we actually have them come farther into internal rotation and then resist. Or you can do it in the manual muscle test position. For the subscapularis test, turn this way, hand behind back, we just do the lift off test, so going straight back and then trying to resist, pushing in on that one. And for teres minor, we actually are just in supine, and just to isolate the teres minor, we are just resisting internal rotation in this position here. So those are the most specific tests to rule in for each of those muscles. Okay, if we wanted to move into a slap tear, there's a lot of different tests you can do for this one. A ton of different ones out there just because of the way the labrum is and the way that the bicep attaches to the labrum. The most specific test for this one at 89% is the compression rotation test. So we're in this position at about 90 degrees, adding compression and towards the glenohumeral joint, and then applying a rotation internal to external, looking to go about 45 degrees either direction on that one. This one is the best because it doesn't load the bicep as much as all the other tests do, so it's better to rule in on this one. Of course, we can do a bicep load test, which has decent specificity, but also would not be able to differentiate from bicep tendinopathy, so we're at about 120 degrees of shoulder abduction with the forearm pronated, elbow flexed to 90, and he is resisting. I'm pulling him into extension. He's resisting into flexion there, looking for ow. With that one, again, not very good at ruling out bicep there. Actually, Mansk et al. Includes in their prediction rule 2 sensitive tests to rule out plus 1 specific test equals a specificity of 90%. A more sensitive test being the compression rotation, and O'Brien's, which I'll do in a second, and then apprehension, which we know is here, pushing into external rotation, and then feeling for that patient to be apprehensive of this motion at the glenohumeral joint. Of course, if we do feel a shift, we can reload that back into a relocation test as well if we're looking more at ligamentous testing. Okay, and then on the edge again, sorry, making him move a lot. Okay, and then we can do speeds and O'Brien's pretty quickly and together. 2 different ways to do the speeds test, one where we do actual active flexion and one where we're just already holding it there. The literature is mixed over which one is better. So because I want to turn it into an O'Brien's as well, I'll go ahead and have you hold straight out at 90, and I will just resist here, looking for ow, and then turning palm down into internal rotation as much as possible, resist again there. In theory, this position loads the labrum, and this one loads the bicep, but we know that both load both, so not the best test there. Can also add Jurgensen's where we're just here and I'm having him resist me as we go in that way, looking for this motion there. All of those tests can be used to help rule in or rule out a slap tear. They're just not great unless we use a bunch of them together, and we're more so ruling out subacromial pain and rotator cuff to help try to rule in the labrum. Another thing we would need to rule out if we want to rule in the labrum is AC joint pathology. The most sensitive for the AC joint is actually just palpation over the joint itself, seeing if that replicates symptoms, because in theory that is more superior than the labrum. So in theory you wouldn't get pain if it's labral versus if it's true AC joint. Because if we do typical AC joint tests such as a horizontal reach, that would still impinge the labrum and the bicep tendon. We can still do that painful arc and look for pain only in the last 10 degrees of motion, and those are all from Walton et al. And then finally, looking at ligamentous testing, I pulled this from Zanz and Merle testing. They have a few different tests included there. One that we all know, I'll do this arm, looking at the sulcus sign. So just letting him be relaxed here, I will give a pull, and we're really looking between, at the glenohumeral joint, between that acromion and the humeral head, we're looking for a sulcus, basically. Greater than 1 centimeter is positive. Up to 2 centimeters would be the most impacted, I guess you could say, and that has a specificity of 97% for ligamentous damage. And then we can also do a load and shift sign, which is really essentially just doing AP and PA mobilizations to the glenohumeral joint in a seated position, stabilizing at the scapula, gripping around the humerus, and then trying to go posterior. We're going to test the posterior capsule there, and then load anterior to test anterior capsule, which his doesn't move at all. But there's 2 different grading systems. Percentages is the first, especially looking at anterior. ligamentous testing, 25% diameter of the humeral head is normal, and anything more than that is abnormal. There's also, up to the humeral rim would be graded a 1, past the humeral rim is a 2, and then totally over is a 3. So looking at those different things, that test has a specificity of 100% for ligamentous testing. Obviously, all of these can be applied together, and that's the best for the shoulder regarding special tests, especially ruling in and ruling out for different pathologies. And no one, of course, should be taken in isolation.